Good morning. It's my pleasure to welcome you all here to Grand Rounds and to introduce to you our distinguished Professor Michael Irwin as our speaker today. So Mike is one of the pioneers in the field of psychoneuroimmunology, and he's had an incredibly impactful career. He's more or less spearheaded psychiatry's now robust appreciation of the interplay between inflammatory biology and psychological processes, social processes, emotional and motivational processes. His studies have highlighted the critical role also of sleep and mindful awareness in human health, and he's published more than 400 research articles over the course of his career, several books, pulled in an average of one new NIH grant every year for the last 30 years, and so it's no surprise that he's takes seriously the notion of sleep deprivation and its potential impact on human well-being. It's easy to see how he came to appreciate that. But what's impressive is actually how much science all of this has yielded, and it would be exhausting to, sort of chart the terrains of all the areas in which he's contributed. But he's really received a stunning array of awards, distinguished fellowships, particularly from the American Psychiatric Association, society presidencies in just about every field he touches, many other scholarly recognitions. We are lucky to have him as our Institute's Vice Chair for Research these days. And Mike works really prodigiously at every level of analysis, from molecular signal transduction all the way up to field trials of behavioral interventions and everything in between, from brain imaging to mouse neurophysiology. He received his bachelor's degree from the University of Pennsylvania, his MD from the UC San Diego School of Medicine, completed a residency here, survived the mentorship of Herb Weiner, and thrived, in fact, and then went down to UC San Diego for, I guess, what was maybe 5-10 years, was lured back here to head the Cousins Center, and Mike has really done an amazing job of boosting that to a really impressive level of productivity, where it's now one of the, essentially arguably one of the two most premier institutions understanding mind-body medicine and the role of psychosocial processes in human health. So all that amazing science aside, Mike remains one of our most thoughtful colleagues, generative mentors, deeply dedicated, idealistic, and energetic scientists, and creative thinkers. So let's hear where Mike's adventures in science have taken him recently. Welcome.
Great. Thank you very much. Thank you, Steve, for that very generous introduction. It's a pleasure to come here today and talk with you. It's been about 10 years since I've given grand rounds at UCLA. It's always good to give grand rounds here in your own home territory. It's interesting, I'm more anxious about giving grand rounds here than I am in most other places that I go. But anyway, we're going to go through a lot of information today. So everything I'm going to be talking about is going to be cited. There's a cited article, and it's all evidence-based. There's nothing, no conflicts of interest, and nothing to disclose. So a journey of 1,000 miles begins with a single pitch. So let's go ahead and begin. So I really have three major areas I want to talk about today. I want to talk about depression and biobehavioral risk profiles. I want to examine what degree sleep disturbance leads to an inflammatory biotype of depression. And then I really want to talk about the new directions that we're taking, looking at innovative mechanistically informed community-based clinical trials. And I think it's very important as we look at the risk profiles of depression to think about how sleep can be a very important target for depression prevention. We're currently finishing a trial on that particular topic, examining how sleep regulation of the inflammatory dynamics actually can be used to refine our understanding of reward-based treatments of depression, and specifically the mechanistic studies that we have conducted in that question. And then I think what I'm very excited about is the new directions about using and evaluating the efficacy of mindfulness-based treatments. We have a mindfulness awareness research center here, and it has a huge education program, and it has a huge delivery of mindfulness throughout the community. And there's many other places throughout the country that do that. But we're one of the few places, if not the only place, that's rigorously testing the efficacy of these mindfulness approaches for sleep health and also underlying biology. So first of all, I want to talk about understanding the risk profile of depression to advance precision-based monitoring and prevention of depression. When I first got into this about 10 years ago, there was a meta-analysis that was published in the American Journal of Psychiatry on looking at the risk factors for depression. And what's really striking about these risk factors is certainly we knew being older, being female, less educated, unmarried, disability, all are associated with increased risk of depression. As you go through this list, what you're really struck with is that all of them are essentially non-modifiable risk factors except for sleep disturbance. And sleep disturbance is really the only modifiable risk factor that can be identified that we might be able to target to alter the ultimate risk for developing a depression. And that intrigued me to really move forward in our work about understanding how sleep disturbance can lead to depression. So what is sleep disturbance? This is a beautiful quote from William Shakespeare. "A heavy summons lies like lead upon me, and yet I would not sleep. Merciful powers, restrain in me the cursed thoughts that nature gives way to in repose." It really strikes at, this kind of notion, what goes on in people that are having problems sleeping. And of course, another way of looking at this from the New Yorker is, we're lying asleep and we're just got tons of things going on in our minds. And I want you to remember that, to think about, what happens with mindfulness. Mindfulness bringing us back to the moment and quieting our mind. So sleep disturbance is defined by rigorous criteria by the DSM-5 as insomnia disorder, and is essentially a constellation of complaints with sleep quantity or quality, associated with difficulty initiating sleep, maintaining sleep. That is, you can go to sleep, but you can't go back to sleep if you wake up throughout the night. And that's one of the most common disturbances of sleep that occur, particularly in older adults, not being able to go back to sleep. And that one characteristic of sleep disturbance, the difference in maintenance, leads to the significant daytime dysfunction of all the kinds of problems with sleep, difficulty going to sleep or waking up too early. In addition, it must cause us significant distress, impairments in social, occupational, educational functioning lasting at least 3 nights for at least 3 months. And that's the rigorous criteria. But as you know from your own experience, many of us have sleep problems that will occur maybe for a couple of days over the week, or for even many days over a week for several months. As we progress in that severity and it produces daytime impairments, that's the actual occurrence of insomnia. But the presence of sleep problems is much higher, particularly in older adults. In our clinical populations, we find that 60% or so will describe insomnia complaints. And those insomnia complaints, as you'll see in the data, are meaningful in that they predict risk for depression in and of themselves, independent of just having insomnia. So insomnia is thought about, when we think about a depression, insomnia is obviously very comorbid with depression. Almost all depressed patients will report difficulty sleeping. That's part of the diagnostic criteria for insomnia. So it's viewed as a symptomatic dimension of depression. And importantly, many of the antidepressant medications that we use will also produce sleep disturbance. So it can linger even after that depression is treated. And its persistence can often indicate a residual phase of that major depressive disorder. So that's how the clinicians have often thought of insomnia. But there's also now an emerging literature that shows that insomnia is not only a prodromal symptom, but maybe a risk factor. People that are not depressed, that have sleep disturbance, may be at increased risk for depression. In fact, some of the earliest work that was done in this area was about 10 years ago, led out of our collaboration in the shingles prevention study. We had access to over 350 community-dwelling older adults that have been rigorously evaluated as being not depressed or with a history of depression, and they were followed for 2 years. And Dr. Jin Cho in our group, who was a postdoc at the time, led an analysis of those data looking at to what degree sleep disturbance assessed at a single time point when they came into the study, when they were not depressed, predicted the subsequent occurrence of depression as diagnosed by DSM-5 or DSM-4 criteria and SCID interview in that 2-year follow-up period. And the findings are really quite striking. These show that group status, that is, whether or not you had a prior depression or not, was a huge predictor, but obviously that's not a modifiable risk factor. But also sleep disturbance was a significant predictor. And this is the survival curve showing that almost all of the cases of sleep disturbance among the people that had a history of depression were due to the presence of sleep disturbance at that single time point, with an odds ratio of about 3. Importantly, in that table, you'll also notice that people were being treated with antidepressant medications. And the use of the antidepressant medications was not fully protective and altering that risk profile for sleep disturbance, indicating this having an independent effect on predicting that risk. We went on to further evaluate what about people that have a persistent sleep disturbance? That is a sleep disturbance that's lasting over 1 year, and then following those people for the subsequent year and seeing to what degree sleep disturbance that's persistent leads to that increased risk of depression. There, the findings are really quite dramatic, showing an odds ratio of 16. That is huge risk of developing depression. So if you have a patient that has an ongoing persistent sleep disturbance, they're at very high risk for developing a depression. And this was occurring in people that with or without a prior history of depression. And the intermittent history of sleep problems had an intermittent risk profile. But I want to emphasize that not all people that have sleep problems will get depressed. So we've been very interested in what are the triggers that can lead to that. Certainly stress can lead to that. So coupled with a sleep problems, the occurrence of stress may actually initiate a depression. But we've also been interested in the potential biological profile. What are the changes that occur biologically that may lead to that depression? We know, and you'll hear a little bit about this later in the talk, that inflammation is a significant risk factor for depression. And interestingly, patients with an inflammatory disorder have about a 2 to 4-fold greater risk of both insomnia as well as depression. So we began to think about, is there a possibility that there's a two-hit model that is both insomnia and or sleep disturbance and inflammation are together conspiring to produce an increased risk for depression. So we examined that question. We had, once again, the opportunity here at UCLA, and great colleagues, and this is a collaborator of ours in the center for many years, Liz Breen, who just recently retired, that worked with Otto Martinez and others here at UCLA in the multi-site AIDS cohort study, which is a very large study of populations, prospective study of men who have sex with men. In this particular sample, we had a sample over 2,200 people, 21,000 person visits. They were evaluated every 6 months for 12 years with assessments of depression, assessments of sleep problems, allowing us to look at to what degree that sleep disturbance is predicting. Now, I emphasize in this particular study that we looked at HIV individuals because even in an untreated person that's treated with an antiretroviral medications, there's HIV, and has undetectable HIV, there's still high levels of inflammation. So it's a population that has an underlying inflammatory component and then coupled with a very high prevalence of sleep problems. And we postulated that the two factors together, the HIV status and sleep disturbance, would interact to produce a greater risk for depression. In fact, that's exactly what those analyses shown, with this marked increase in, I guess you can't see this now, marked increase in the individuals who have HIV and sleep disturbance. There it is. It's just very, very faint, as shown here, with a marked about a doubling of the rate of developing a depression. So that indicates that individuals that have an underlying inflammatory disorder that then have an occurrence of a sleep disturbance are very high risk for developing a depression within that 6 months. In the HIV individuals, that depression was occurring again and again and again, and often lasting for many months at a time. Very atypical kind of depression that we see in many of our other clinical populations. But we've been very interested in beginning to ask and interrogate what are the mechanisms or what is underlying that risk or that link between insomnia and depression, and what affective mechanisms are being altered by the sleep problems that are producing that risk. And we know that a very important component of a depression is anhedonia, the loss of pleasure, and that changes in the reward pathways, which are implicated in the occurrence of depression, may be affected by sleep problems. And so reward is essentially a reduced motivation for receiving reward or pleasure, or can be reduced sensitivity. That is, that you're exposed to the reward, but you don't experience it as pleasurable. So there's this wanting and liking aspect. And so we know that this particular component, reward, is very important. It's altered in depressed patients. It predicts depressive symptoms, suicide risk, and also depressive episodes. Another component, another early mechanism associated with depression is alterations in facial emotional perception. Interestingly, patients that have a major depression have an impaired ability to recognize sad faces. So we've been interested in to what degree changes in these two mechanistic processes could be altered by sleep. And we're currently engaged in these studies at present. The current study analysis is led by Chloe Boyle, a postdoctoral fellow in my group, who just recently won the Friends of the Semel Award for a scholarship. And in this particular analysis, she's looking at to what degree insomnia, the presence of insomnia, blunts motivation and sensitivity to monetary reward. And what we've discovered in this particular trial, what we're looking at is ability to essentially win money and alterations in the activation of these reward processes. In this particular study, we evaluated 31 insomnia patients that were rigorously diagnosed, comparison controls, and then they had this behavioral reward task, the effort response task. We also looked at systemic inflammation. And what the findings show is that insomnia essentially blunts that motivation and sensitivity to monetary reward. And that effect is greater in men than in women. We were somewhat surprised by that. Women in general show a decreased interest and want for monetary reward as compared to men. No surprise to probably many people in the audience. But what's interesting is that men who have insomnia show a much greater decrease in that monetary reward sensitization or activity than women do. And the men that show higher levels of inflammation are particularly sensitive. So there's a coupling, once again, of this insomnia and inflammation to alter a sensitivity to this reward process. Another study looking at this particular, that's also currently under review, is looking at not only just reports of insomnia, but actually objectively evaluating the sleep disturbance. And we know that when we are sleeping, for example, last night, did you sleep well? And how did that sleep in that prior night impact how you function the next day? And how did you respond to reward processes the next day? And in this particular case, we're looking at facial emotion processing. And so this is a work that was led by Dominique Pieper, who came to us from Germany under Max Cade Fellowship. And he worked with us for 2 years in conducting this particular study and proposed that disturbance in particularly sleep continuity might interact to predict impaired facial emotion processing. The design of the study is very simple. We brought people into the sleep laboratory, objectively evaluated their sleep using polysomnography, and specifically characterized sleep continuity measures, the ability to maintain sleep over the course of the night, and then measured systemic inflammation, and then exposed them to this facial emotion processing task. It's a fairly simple task of allowing people to look at facial emotions and recognize those facial emotions. And this particular facial emotion is a sad facial emotion. At some point, as you're exposed, the face essentially morphs over the exposure of the slides from a very neutral face to a very sad face. And what we found is that what we know is that patients that have a depression have a delay in the ability to recognize that sad face. And also the individuals that had disturbances in their sleep continuity had a delay in the ability to recognize that sad face. And interestingly, if they had high levels of inflammation, that was also the case. That is, that it interacted, once again, an interaction between this inflammation and insomnia predict these alterations in this emotion regulation process. We can also look at the ability to rate the intensity of that particular emotion. If you've been told it's a sad face, how sad is that face? And once again, inflammation and insomnia interact to produce a blunting or impairment in that perception of that sad face. Other emotions were not impacted by this, which is very interesting. Similar as in depression, hostility, for example, was not significantly altered. So we've been very interested in how is essentially this sleep disturbance leading to changes in depression risk. And these are very interesting clues suggesting that inflammation may be driving this. So a whole separate line of our research in my program has been trying to understand, does sleep disturbance activate inflammatory biology? And so I'm going to talk for a little bit, about 5 minutes or so, about the role of sleep in the regulation of inflammation. I recently published a review in Nature Reviews Immunology on sleep and inflammation, partners in sickness and health. And basically, this particular review demonstrated a number of studies that showed that chronic mild inflammation can lead to disturbances in sleep continuity, which then, in a feed-forward way, further escalates inflammation during the day and leads to the increased risk of depression and Alzheimer's disease and other disorders. And it does so by altering primarily changes in the sympathetic nervous system processes. Sleep disturbance can activate the sympathetic nervous system. It can lead to activation of beta-adrenergic receptors on lymphocytes, which then produce this increase in pro-inflammatory gene expression, ultimately the expression of pro-inflammatory cytokines. And one of the things that we've really championed at the Cousin Center, this is a big advertisement for the Cousin Center, is the ability to look at inflammation across multiple systems. That is at the systemic level, the cellular level, the transcriptional pathways, as well as at the gene expression level. And so we've taken that kind of power and that comprehensive vertically integrated approach to evaluate how sleep and other psychosocial stressors and depression are impacting all components of the inflammatory processes at multiple levels. So before I get into that, what is the evidence that systemic inflammation is being altered? And Jude Carroll in our group and I, as well as our statistician, Rich Olmsted, led a meta-analysis on this particular topic that was published in Biological Psychiatry. Over 50,000 people were in this particular meta-analysis, looking at 3 primary markers, C-reactive protein, interleukin-6 and TNF, and characterizing sleep disturbance as well as objective disturbance of sleep duration. Because both sleep disturbance as well as deficits of sleep duration have been associated with inflammation. And I'm not going to go through all this, but essentially it's very interesting that we do find that sleep disturbance as well as long sleep duration and to some extent short sleep duration are all associated with increases in inflammation. This is a forest plot that's being shown. As you can see, the effect size is moderate or small to moderate. These are the level of effects that you'd see, for example, with other lifestyle factors such as sedentary activity, poor diet, or obesity associated with levels of inflammation. So similar to these other risk factors, sleep disturbance is a lifestyle factor that's associated with increases in systemic inflammation. Now, there's lots of ways of how systemic inflammation can occur. Simply by not sleeping, it may produce an activation of inflammatory pathways. But we also know that people that are not sleeping may be overweight, they may be physically inactive. So all these other factors can come into play. And so the quality of a meta-analysis is only as good as the data that we have for those particular studies. So as a good scientist, one of the things that we want to ask as a group is, what role does sleep disturbance have in actually causing increases in inflammation? And so this is a study that we did now nearly 10 years ago in collaboration with Steve Cole, looking at sleep deprivation, activation of cellular and genomic markers of inflammation. Very simple design, a simple sleep deprivation, a deprivation that's ubiquitous for many of us, for probably the population. That is having people stay up until 3 o'clock and then having a short period of sleep and then going and functioning the next day. And that simple sleep deprivation really remarkably produced this marked increase in the cellular production of pro-inflammatory cytokines. This study was elegant in that it looked at the cellular source of inflammation, that is the monocyte population, characterized them using flow cytometric analyses, and evaluate to what degree there's an increase in the production of pro-inflammatory cytokines. In a person that's sleeping well uninterrupted, most of the monocytes are not expressing cytokines as shown here, but simply with a night of sleep deprivation, you can see that many of these people, these cells, are now expressing pro-inflammatory cytokines. And importantly, it's not just all people. Women are exquisitely sensitive to that. So both men and women show increases in that inflammation when they first wake up. But men, over the course of the period of the day, normalize fairly quickly. Women continue to show elevations in that inflammation throughout the day with simply that night of sleep deprivation of short duration. And that's due to this differential activation of NF-kappa B. NF-kappa B is a transcription factor that triggers the pro-inflammatory cytokine pathways. And women, once again, show this marked activation of NF-kappa B signaling as compared to men following that increase. And then importantly, Steve, in this early investigation, really did really elegant work looking at the gene expression profiles. And quite frankly, at the time when we were doing this study, it was very exploratory. We had no idea that genes would be differentially regulated. And so we characterized it with probably 21,000 genes. And what was really striking about that was there were 21 genes that were differentially regulated, and 14, about 3/4 of them, had to do with the immune system, and particularly the inflammatory process, which is a really striking finding. And we were very intrigued by that and showing that these early findings that those genes that were differentially regulated were in fact due to an activation of NF-kappa B, which we subsequently went on to confirm that. So sleep deprivation can lead to this, disturbances of sleep can lead to this inflammation, but what if we treat the sleep disturbance? Can we actually normalize that inflammation? And we've also demonstrated that when you expose individuals to cognitive behavioral therapy for insomnia, have a full remission of that sleep disturbance, and then follow them people over a period of time, in this case 16 months, we find that there's a significant decrease in C-reactive protein. It goes from essentially a high-risk profile that is greater than 3 picograms per mil to less than 3 picograms per mil. I'm not going to have much more time on this particular area of my talk, but we're very interested in how that inflammation can conspire at the cellular molecular level to lead to progression of cellular aging. And this is the work that's led by Jude Carroll in our group. And I invite you to have her come and give a grand rounds because she's doing very exciting work about how sleep disturbance can accelerate biological aging processes, including telomere shortening, activation, decreases in telomerase, changes in other markers of cellular aging. And then, so this is my advertisement. In a couple of weeks or a couple of months, we're also going to have a sleep medicine day at UCLA. And I published with a group up in, a co-author up in Seattle in Lancet Neurology this last year about how sleep disturbance through these changes in biological aging processes can lead to cognitive aging and potentially be a risk factor for Alzheimer's disease. And so you'll hear that talk if you come in February. So, do you have any Y2? This gives me a chance to have a breather. And you to give a breather. So this is a molecular structure for CRP. And so let me talk then about beginning to bring some of this together. So, once again, I had this I'm really grateful for the great people we have here at UCLA. And so one of the people that we came from UCSF was George Slavich. And we wrote back in 2014 a review in Psychological Bulletin, which we really postulated that stress and inflammation, once again, are very important. And we proposed a social transaction model of depression in which they together interact to produce depression. And it's interesting in this particular review, which is already quite lengthy, we really couldn't get the reviewers to include in that center of that circle sleep disturbance, because sleep disturbance is really also at the center of that circle, leading to elevated inflammation, ultimately anxiety and depression. As I mentioned, there is a link between depression and inflammation, and I highlight in this particular study my K Award person, Jennifer Cruz, is working very closely to look at in the UCLA program about the associations between inflammation and depression. We know that elevated levels of cytokines are found in depression, that inflammation alters these neurotransmitter signals involved in regulation of mood and behavior, and that it's prospectively associated with depression. And what Jennifer's done is very important. We also know that high levels of inflammation predict changes in the response to antidepressant treatments. So if you have high levels of inflammation and are exposed to an SSRI medication, you're less likely to show a favorable response. In contrast, the individuals that have high levels of inflammation that have ECT show a more favorable response. So this kind of the first data that says that these biotypes of inflammation associated with depression may help clinicians assign various treatments based upon these biological profiles related to inflammation. And then this raised the whole notion that anti-inflammatory strategies may also show potential. I'm going to come back to that point in a little bit later. So one of the issues in all these data is most of them, if not all of them, are correlational. They're naturalistic observational studies. Certainly the prospective studies begin to suggest or demonstrate cause, but they don't actually evaluate cause. And so we have really led this notion that we need to evaluate to what degree inflammation that may occur acutely can actually cause or lead to depressive symptoms. To do this, we've really turned to a human biological agent called endotoxin, which is not the bacteria, but the bacterial cell wall. And LPS, as demonstrated in this review written by Anthony Seferdini at NIH, who really heads up the endotoxin program at the national level, that human endotoxin has been used hugely throughout this country and the world to evaluate underlying biological processes and primarily understand the processes of septicemia and how septicemia can occur. But if you back titrate that levels of LPS to very low levels, what you see are changes in mood and changes in cognition. And so let me talk with you about some of those data. So I want to emphasize that this is safe. We've been doing this now for over 10 years. We've had zero, at UCLA, zero significant adverse events from this treatment. So this is a study that was published by Jonas Honnestad in Neuroimage a few years ago. Jonas was actually a postdoctoral fellow when I came to UCLA in 2001. It's so wonderful to see kind of the influence that UCLA had as he moved to Yale to evaluate endotoxin-induced systemic inflammation, activating glial sites within the brain in this non-human model. So inflammation that's occurring out in the body is being transduced immediately to the brain through the vagus nerve to activate areas in the brain, including particularly the glial cells, and producing inflammation. So Naomi Eisenberger, who was a postdoctoral fellow, now is a full professor in the Department of Psychology, really was the first people to lead an fMRI study looking at cytokine-induced depressed mood and social pain, and show that inflammation is a molecular signal to induce depressed mood. Once again, when we give endotoxin, we see a very small, an increase in interleukin-6. This increase that's shown in this particular study is really quite robust. We find that there's huge variability. Some people will show only modest increases. Some people show several-fold increases. Some people show a 100-fold increase in inflammation. So huge variability in that inflammation. And that variability in that inflammatory response, despite the standard dose of endotoxin is given, can be exploited to understand how inflammation is communicating to the brain. So in this particular early study, we evaluated adults, a double-blind, placebo-controlled randomized trial of low-dose endotoxin, behavioral measures of social distress, and neuroimaging. And what we showed, or what Naomi showed in this particular study, is that increases in IL-6 was associated with activation of the anterior insula, the prefrontal cortex, and also the temporal sulcus. But interestingly, when you look only at in females, IL-6 is associated with sites involved in mood regulation, particularly the dorsal anterior cingulate cortex and the anterior insula. And these changes in activation of these brain sites essentially mediated the changes in the mood. So inflammations mediating changes in the DACC, which ultimately drives increases in depressed mood, but only in females. Males appear to be protected. Now, this is a small study. So we went on and got a NIH grant, Naomi did, a perfect score, I should brag for her, on that NIH grant, a 10 on the first submission. And she demonstrated, and this is a report in neuropsychopharmacology that won the transformative report that year, showing that women are exquisitely sensitive to endotoxin. Despite similar increases in inflammation between men and women, only women will get depressed mood following that inflammatory challenge. And that's shown here. Men are showing this increase, and also this increase in social disconnection. Interesting, we look at anhedonia measures. We find that inflammation blunts endotoxin, blunts ventral striatal responses to reward. This is a monetary reward. Decreases particularly in the ventral striatal area. And this is occurring both in men and women. So both men and women are equally sensitive to reward. It's not only these processes involved in depressed mood and social connection, but how we're responding to social signals may also be important, much as the inflammation insomnia interaction studies that I've also talked with you about spatial emotional processing. In this particular study, Tristan Inagaki in our group evaluated threatening emotional responses and found that people that are exposed to endotoxin show heightened activation of the amygdala in response to that threatening image if they had an underlying exposure to that inflammatory challenge. So coming back to this link between sleep and inflammation, we rigorously tested this with Jen Cho's leadership of a study looking at pre-existing sleep disturbance and finding that when individuals had a sleep disturbance before they were exposed to endotoxin, they were the ones that showed this marked increase. People that have no sleep disturbance have really a very modest increase. So all these data suggest very clearly that sleep disturbance is interacting with inflammation, leading to this vulnerability. So I should relax this. Okay. So building an evidence base to accelerate sleep health and community treatment. And this is kind of where I'm going with my career right now, because I'm very interested in mindfulness and to what degree mindfulness and these community-based interventions can be used to alter these pathways, both the risk of developing depression by targeting sleep and also the underlying biology. I suppose before I get to that, we should say, well, why take that tactic? Why not, if you know that inflammation is so important, why not just target inflammation? Inflammation, in fact, this is actually a medical student here at UCLA that worked with me and now is at Penn in the residency program, where we reviewed this literature. I'll talk about just a minute about it. But essentially, peripheral inflammation is activating pro-inflammatory cytokines in the periphery. And as I showed you already through Jonas Hannestad's work, is producing an activation of the glial cells in the brain and increases in pro-inflammatory cytokines in the brain, which then alter MAP kinase, decreasing serotonin availability, increasing glutamine release, so altering the underlying neurotransmitters that we know are very much associated with depression. So it would be very logical for us to say, let's just target inflammation, right? So that's exactly what many people have been doing. And unfortunately, when we review this literature, looking at non-steroidal anti-inflammatory pathways, aspirin, prostaglandin inhibitors, cytokine antagonisms, with, say, infliximab, which blocks actually the pro-inflammatory cytokines, the action, NMDA receptors with ketamine, chirunin modulators, minocycline. All these strategies yield very mixed results. In fact, the early promise of using a cytokine antagonist, which has been championed by the Emory group, has not been replicated. There's a paper now published in JAMA Psychiatry from Stanford that basically shows even in an inflammatory enriched population, people that have high levels of inflammation, which in the Emory group's finding are the only ones that are able to respond to the antidepressant effects of the TNF blocker. In that study, they failed to find any effects at all. So we're not really finding a robust signal. And that really raises this notion that I think Steve and I, talked about in a review of this now some time ago, that inflammation is occurring in this whole context. And it's occurring not just through targeting one particular cytokine, but it's involved that there are multiple cytokines that are regulating the inflammatory dynamics. And there are multiple processes on top of that that are regulating those inflammatory dynamics, including the sympathetic nervous system, the hypothalamic pituitary adrenal axis, and how we're interacting with our environment day in and day out, and our perceptions of stress. So it might be that we need to take a whole body approach, a mind-body approach, to really be effective in altering inflammatory processes and altering potentially that risk for depression. Now, as a sleep researcher and very interested in sleep treatment, any of you might say, well, let's just do cognitive behavioral therapy. Cognitive behavioral therapy is the treatment for insomnia. It's superior to sedative hypnotics in terms of its safety profile. It has a long-lasting effect, lasting over a year after a single exposure of 4 to 6 weeks, 8 weeks, and it's been recognized as the gold standard for treatment. However, if you look around this country, and if you look within UCLA, you find, up to about 6 months ago, you find no program that uses CBT for the treatment of insomnia. In fact, the number of therapists that are available for treatment, CBT-I, within healthcare systems is very few. I remember being at Cleveland Clinic and talking to them. They had one program. They had 4,000 people on their wait list to get into that particular program. Okay, so we've come here at UCLA, and we're certainly offering CBT-I, but it's expensive. Access to it is still going to be an issue. And so about a year or two ago, I really argued that in particularly in breast cancer populations or in cancer populations that have high levels of insomnia, that have very high levels of depression, might we need more innovation, more community-based accessible programs that can be delivered to patients that are undergoing the stress of cancer diagnosis and treatment, and talked about the efficacy of mindfulness meditation and Tai Chi. And so I know that Marv Belzer is here today. He really is the associate director for the mindfulness program. I hope he likes my definition of mindfulness. It's a state of consciousness characterized by attention to the present moment, and that mindful awareness is essentially teaching people the systematic practice to attend to the moment experiences, thoughts, and emotions. And this is critical from a non-judgmental perspective. So think about that. So if you're waking up in the middle of the night and you're beginning to worry, letting those worries be here and coming back to being present in the moment. That's very different than what CBT does. CBT would say, if you wake up, we want you to get out of bed, remove yourself from that bed where you're having difficulty sleeping until you get sleepy again, then go back. If we're going to use mindfulness for these patients, we're going to say, just stay in bed and be present in the moment until you go back to sleep. So I didn't think it would ever work. But David Black, who is a postdoc in our group, he was very dedicated, almost a zealot to mindfulness meditation. He said, I want to do this project. And I rarely advise fellows, postdoctoral fellows, to do a randomized controlled trial during their training, but he moved ahead and we published that in JAMA Internal Medicine. It's a small trial. 49 people randomized to MAPS intervention, which is a mindfulness practice. It's available in the MARC program. It's a research curriculum based upon mindfulness-based stress reduction, but it is accessible as compared to MBSR, and that we do not require a retreat, a full-day retreat. If we're going to make a program available to the community, asking people from diverse populations that are maybe socioeconomically challenged to take a retreat for a full day is not going to fly. So we're using a radically accessible treatment, mindfulness awareness practices limited to 2-hour sessions for 6 weeks, teaching them the practice of mindfulness. We're delivering it, and initially the challenge is getting people to adhere to it. In order for any of these practices to work, people have to adhere to it. So we asked people to initially practice 5 minutes, increase it to 10 minutes, and by the end of the study, be at 20 minutes a night, or 20 minutes. In this particular study, we had them practice the mindfulness before they went to bed as part of their bedtime routine. So as they're getting ready, instead of watching TV or whatever they're doing on their computer, go and practice mindfulness. You can practice in bed, quiet your mind. If you wake up, use it again to practice. And what we found in this pre-post design is that a significant improvement, that a decrease in the sleep quality index indicates an improvement. And the effect size that we found here was comparable to that with CBTI. Really remarkable. I could not believe that this simple strategy could produce an effect comparable to cognitive behavioral therapy, also improvements in depressive symptoms. So we went on and really had the opportunity to look at this question in breast cancer survivors using a different modality called Tai Chi. Tai Chi is a slow-moving, meditative movement meditation, essentially, asking people to practice, teaching them to practice Tai Chi during the day, and not obviously at night, and then evaluating the comparable non-inferiority of Tai Chi practice, this mindfulness practice, to cognitive behavioral therapy. And this was published in Journal of Clinical Oncology. We had a intervention period and then a follow-up for 1 year in 90 breast cancer survivors. These data were really dramatic. They were the first to show that a mind-body intervention was non-inferior, that is, or similar, to the state-of-the-art or the gold standard treatment for insomnia, CBTI. When we look at response rate, when we look at remission rate, and the maintenance of that remission rate over the 6-month, over the 1 year follow-up. And interestingly, in the review process, because I think JCO did not kind of want to see this published, even though it turns out it was like the most highly downloaded article from JCO that year, which is amazing. But one of the things that they asked us to do is that we had differential dropouts. And so usually what you say is, you say if you have differential dropouts, you say everyone that dropped out is going to be a success, or everyone's going to be a failure, and you see if you still have an effect when you do that. In this case, they said if you have a dropout in the CBTI, that is a success. If you have a dropout in the Tai Chi, that is a failure. So it really produced this huge disadvantage. And despite that, the non-inferiority statistics remained. And you can see that looking at the PSQI data, where it's essentially right on top of the two groups over the period of time. And similar improvements in depressive symptoms as well as fatigue. So this particular treatment, these mindfulness approaches, are very effective, equally effective to CBTI. So coming back to this role of inflammation, and Julie Bauer and I have been obviously in this arena for a while, and we wrote a review about mind-body therapies and inflammatory biology. And what we've discovered is that mindfulness practice in Tai Chi is more effective at reducing that cellular inflammation. Remember that flow cytometric plot where we looked at all those monocytes? We characterized the cellular production of pro-inflammatory cytokines in individuals before or after they exposed to CBTI or Tai Chi. And in the breast cancer survivors, despite equal effects to improve their insomnia, Tai Chi was able to produce a greater decrease in the cellular production of pro-inflammatory cytokines. We replicated that in an older adult population. That's in the second panel here, about 103, 110 older adults who were followed over a whole year, and found that Tai Chi uniquely decreased that cellular production of pro-inflammatory cytokines, even though CBT is producing improvements in insomnia. So yes, insomnia is important, but by targeting these stress response pathways, we also know that these pathways can alter or decrease the inflammation. But I don't want to dismiss the notion that, before I get to that, yes. And also when we look at the gene expression profiles, we find that Tai Chi, these mindfulness practice, is more effective at reducing the gene expression profiles in the breast cancer survivors with insomnia. But I don't want to sort of negate the possibility or the notion that CBTI, by its effects on insomnia, has no effect. because that's not the case. What I've been primarily comparing is how the Tai Chi or the mindfulness can actually is greater effects than CBTI. But when you look at both of those treatments and compare them to a control condition, you find that both CBTI and Tai Chi can reduce this inflammatory process. So CBTI only by improving sleep. Tai Chi is clearly improving the sleep, but also in targeting these stress response pathways. And finally, as I kind of end, it's not just mindfulness practices and Tai Chi, but a whole variety of different ways of practicing mindfulness. And this is Julie Bauer's work, again, with breast cancer survivors who were depressed. She used the MAPS research protocol, finding this decrease in gene expression in these breast cancer survivors. Helen Lavretsky is a collaborator of ours as well for many years, used a mantra meditation, finding that it could reduce this pro-inflammatory gene expression. And then David Creswell, who really pioneered this work in our group probably over a decade ago when he was a trainee with me. Now he's at Carnegie Mellon, showing that the administration of MBSR in lonely older adults also decreased this inflammatory profile. So kind of an ending, there's many ways of getting there. You can do mindfulness through our program. You could do mantra. You can do MBSR. You could do Tai Chi. You can probably do yoga, and there's findings also that yoga produces very similar effects. So the critical point in all this is that people have to practice these in order for those benefits to be maintained. So I'm cognizant of time. I'm going to leave some questions, but I do want to provide you with a summary. It's kind of action clinical items. This is clinical grand rounds. So basically, that sleep disturbance is a robust risk factor for depression. It's amplified in association with inflammation. It does produce that risk, we believe, through dysregulation of the reward and emotional sensitivity processes. So patients with sleep disturbance should be monitored for that increased risk of depression, and if that's persistent or comorbid with an inflammatory disorder. Sleep disturbance induces inflammation, similar to the adverse effects of other lifestyle factors. Treatments that target sleep behaviors reduce inflammation, possibly mitigate the risk of inflammatory disorders such as depression, but they also may be impactful for many other diseases, such as Alzheimer's disease. And that was the point of the Lancet Neurology piece, is that the modifiable risk for Alzheimer's disease, 80% of it is occurring through lifestyle factors that accumulate over our life. And sleep disturbance is one of those lifestyle factors that can be altered to reduce that risk. Inflammation induces depressive symptoms, and importantly, persons with existing sleep disturbance who then have an inflammatory challenge, simply an infection, may be very high risk for developing a depression. And so as clinicians, you should be looking, particularly for older adults, they're having problems with their sleep. Suddenly they have a UTI or a cold. Those kinds of coupling of those factors may markedly increase the likelihood of them developing a depression, and that can be targeted by approaches that enhance reward motivation and regulate emotion. And then finally, these mindfulness interventions are scalable. They can be delivered at very low cost. In fact, we're currently conducting a trial with Alzheimer caregivers using MAPS versus CBTI and doing a cost-efficacy analysis embedded in that clinical trial to demonstrate really the favorable profile of these mindfulness approaches in community-based delivery to mitigate this risk of syndromal insomnia and depression and also diseases of aging. So thank you very much. I wouldn't be able to be here without getting a lot of grants, as Steve talked about, but really it's really the people. And I think I've really tried to call out all the people that I've worked with over the last few years that have contributed so much to this program. But there's many, many more people. And this is a small group after dinner the last couple of years ago. And this is the group over 15 years ago. And many of these people are still circling around in our group working with us. And so it's really nice to see that continuity. So thank you very much. So thank you very much, Michael. Do you have a microphone? No. Questions? Yes. Let's see if we can make this thing work.
Thank you. It's really impressive. So I used to do immunology 30 years ago. I'm over here. And just know what a daunting thing it is to take on this interdisciplinary and how you've really built a foundation. I was wondering just your sense of the CBTI versus the Tai Chi in terms of inflammation. How do you have any sense how much the physical exercise component of that is reducing the inflammation?
That's a really great question. And, systematically in all these trials, we evaluate physical activity. And surprisingly, the physical activity, when we look at metabolic equivalents per day expenditure, does not change compared to baseline in the Tai Chi group. Why? Because instead of doing their walk, they're doing their Tai Chi. So they're simply substituting another aerobic exercise. So it comes back to this active component of the Tai Chi, which is the mindfulness, the quieting of the mental processes that then carries forward throughout the day. Yep. Question? Yeah, go ahead.
So I recognize that you said that anti-inflammatories have been disappointing, but I'm wondering if there's any efforts to combine anti-inflammatories with meditation, Tai Chi, yoga, anything else, whether the two could have a synergistic effect, one facilitating the effects of the other.
Yeah, great idea. And there's obviously a discussion. I'm sitting on a review panel for NIH grant reviews. It's always interesting when we see grants when the panel sees grants that have this combinatorial, there's like double or triple the questions, So they're very hard to get funded, but that's exactly what we need to do. And importantly, we also know that many older adults not only have a sleep disturbance, they have problems with circadian regulation. And these are also very important in circadian process and regulation of inflammation. So we've also talked with Phyllis Z at Northwestern about combining CBTI with circadian processes in a grant that may be more effective. I didn't note this, but if you looked at the information I presented, you'd see it that only about 50%, we're a little bit better, maybe 50% of people do not respond to CBTI. We're a little bit better, about 60% will respond, but that's because we have a mood regulation component in it, I think. So there's a lot of room for improvement in CBTI's effect. So by doing these combinatorial approaches, we hope to achieve that.
Yeah, I have two questions. One of them is that CBTI is often being used mindfulness within it now. And are you using that or are you keeping the approaches completely separate?
So the insomnia treatment clinic that we developed has a CBTI that's strict.
Right.
And then a mindfulness-based behavioral therapy, which incorporates some components of the CBTI, such as sleep hygiene regulation,
right,
and then mindfulness. So we are keeping those separate.
Right.
We're going to look at patient preference and helping making some of those clinical decisions and to see what people feel. And we're also going to direct people that have more life stressors to the mindfulness. But I think this need to integrate the two may actually get to this other question that we just had, increase the overall efficacy. And particularly when we want to look at the underlying biology.
Right.
So CBT may improve sleep, but having a mind-body treatments or mindfulness component may be very important for decreasing the inflammation, which can perpetuate, we know, can lead to insomnia or just difficulties in sleep regulation.
Right. The other question,
I'm afraid I'm going to have to stop because I know Michael has another meeting at 12 and I do too. But I just want to say, Michael, I think this is wonderful. I've been reading a lot of Marcus Aurelius recently, and he obviously had been reading your papers because when he was camped out in the areas trying to defend Rome, I think it was about AD 180, he had in his journal all sorts of interesting things which are exactly what you were talking about today. So not only do you influence us, you influence Roman emperors. So
they influence us, and it's interesting. You always think you discover something, but then you actually go to the literature and you find, oh, that's already been discovered.
Anyway, thank you so much. A wonderful talk. Come down and make an appointment.